This makes universal applicability of the available guidelines to the Indian population. So for acceptability and better patient outcomes, we should include social, cultural, geographic, and economic factors to be considered. So moving on. So there are various guidelines available, and in addition to our Indian Society of Anesthesiologists 2020 guidelines, and another latest guidelines is updatation of the ASA practice guidelines for preoperative fasting 2017 in 2020. So our Indian guidelines started with the vision and proposal submitted to ISA by past President Dr. Bala Bhaskar. Then core committee was formed with 7 members, which included President and Secretary of ISA, which in turn constituted expert committee who went in formulated research questions, literature, systematic review, and meta-analysis, and then drafted guidelines and published the guidelines in our Indian Society of Anesthesiologists uh, window, that is the IJA, in July 2020 issue. So evidence of recommendations were as per grade protocol, wherein high level or moderate level of evidence was considered as strong and was associated with words like should be, and very low or low level was considered as weak, wherein the words may be were used. So all these guidelines taken into consideration of the fact that solid foods will have a log and biphasic phases of gastric emptying. Solid food will take nearly 2 hours for the 50% of the ingested food to be emptied, wherein liquid food doesn't have any lag, and by the end of 1 hour, 95% food would have been emptied. And it is impossible to have a completely empty stomach because of the continued salivary juice ingestion and also the gastric juice secretion. So 1.5 ml per kg of gastric volume content is acceptable before surgery. So coming to the recommendations of perioperative fasting and feeding for adults, clear liquids should be allowed up to 2 hours prior to administration of sedation or anesthesia, which is a strong recommendation. The volume of clear liquid consumed may be restricted to less than 450 ml 2 hours prior to administration of sedation or anesthesia. Non-clear liquids may be allowed up to 4 hours prior to administration of anesthesia. Light meals up to 6 hours. And if the patient has consumed heavy meals, it may be better to wait for at least 10 hours prior to administration of sedation or anesthesia. And heavy meal consumption is not advisable the night prior to surgery, which is a strong recommendation. Coming to the obstetric patient, women in early or late pregnancy who are undergoing sedation or anesthesia will be considered at high risk of aspiration. And clear liquids may be allowed up to 2 hours prior to surgery and 4 hours for non-clear liquids. Light meals may be allowed up to 6 hours, and there should be a time gap of around 10 hours when women has consumed a heavy meal. And heavy meal consumption is not advisable the night prior to surgery in pregnant women. So this is a strong recommendation. Coming to the aspiration prophylaxis in obstetrics, pregnant women requiring sedation or anesthesia should be administered aspiration prophylaxis. This is a strong recommendation. This may be through H2 receptor blockers, proton pump inhibitors alone, or in combination with the prokinetic drugs. What about obese individuals? Obese individuals may be considered to be at higher risk of aspiration in comparison to non-obese individuals, and the same recommendations which were recommended for adults may be used for the obese patients also. And aspiration prophylaxis may be administered in obese patients prior to administration of anesthesia or sedation. And H2 receptor blockers, proton pump inhibitors, alone or in combination with prokinetic drugs, may be considered as per the obstetric recommendations. So coming to the pediatric patients. So consumption of water up to 3 ml per kg should be allowed until 1 hour prior to administration of anesthesia. And consumption of clear liquids other than water is up to 3 ml per kg until 2 hours prior to administration of anesthesia. And human milk and fully skimmed non-human milk may be allowed up till 4 hours. And non-clear liquids, non-human milk, formula feeds, light breakfast or light meal may be allowed until 6 hours prior to administration of anesthesia. And again, aspiration prophylaxis in pediatric population has to be decided by the anesthesiologist. We're taking into consideration of the condition of the child, age and condition of the child, and the procedure child is undergoing. So now coming to the categorization of the various food items. Clear liquids or the liquids, that is juices without pulp. Examples are coconut water, 25% dextrose, watermelon and pineapple juice, clear soups, dal water, maltodextrin preparations, to name a few. Non-clear liquids, examples are rava porridge, ragi malt, milkshake, coffee, tea, filter coffee. And all these volumes mentioned in the bracket are with respect to adult patients only, and volumes of clear liquid are taken as less than 450 ml unless otherwise mentioned. So coming to the light meal, bread, cream of soups, pulka with vegetable, milkshakes, puffed rice, biscuit with the milk are considered as light meals. Heavy meals include thali, chicken curry, rice, pizza, Coke with Coke and burger. I'm going to share all these charts into our groups, which can be downloaded and displayed in their respective work areas. These food items were categorized based on the survey conducted and elicited the common food items of the various regions of India. And the nutritionist, qualified nutritionist classified them based on the type of food contents and the characteristics of cooking. So when we can start food intake post-operatively? As such, there are no recommendation for adult and obese patients as there was lack of sufficient evidence. For obstetric patient, clear liquids can be allowed orally by 8 hours after cesarean section under regional or general anesthesia. And in pediatric population, the oral consumption of clear liquids in the postoperative period should be resumed at the earliest where no medical or surgical contraindication exists. So both these recommendations are strong recommendations. So these recommendations are done after meta-analysis of studies done in patients who had undergone a cesarean section and classified into early, that is less than 8 hours, and late, that is 12 hours of feeding. There was early passage of platus and resumption of bowel movements in the early feeding group, and the incidence of ileus was comparable in both the groups. Then what are the fasting guidelines for procedural sedation? Again here, the attending anesthesiologist should decide on case-to-case basis and the procedure for which the patient is undergoing. Gastric ultrasonography may be used as bedside tool for assessing the quality of gastric contents in the pre-operative period, and the quality and quantity of gastric content should be assessed in the lateral decubitus position. Studies have used various formulas to estimate residual gastric volume from cross-sectional area of the stomach, and the qualitative assessment is better done with ultrasound compared to quantitative assessment. Few words about the 2023 updated ASA guidelines for preoperative fasting. Again, it reaffirms the previous recommendations for clear liquids until 2 hours preoperatively. Simple or complex carbohydrate containing clear liquid foods appear to reduce hunger compared to non-caloric liquid foods. The addition of protein to preoperative carbohydrate containing liquid doesn't seem to either benefit or healthy patients. And there is no need to delay surgery in healthy adults who are using regular chewing gums after confirming that chewing gum was removed. And allow clear liquids in healthy children as close to 2 hours before procedure as possible. Again, these are the comparison between our guideline, that is Indian Society of Anesthesiologists guidelines and ASA guidelines. The main difference is here the various types of population, that is obstetric, pediatric, bariatric, and ultrasound sections were dealt separately. ISA guidelines also deal with the post-operative feeding guidelines also. And the gap between the heavy meal and the time of anesthesia is 10 hours in our guidelines, whereas it is 8 hours in American guidelines. Again, it is because of the choice and culture of food we ingest in India. And these are the again various recommendations of ISA with regard to preoperative for fasting and feeding guidelines. And these can be downloaded directly from the article, and I will be sharing these guidelines into our PPF group, which can be downloaded and displayed in their respective hospitals. In our place, our ISA branch has prepared these charts and displayed in various hospitals. We are doing that, and these are few of my references. Thank you for the patience here. Thank you.
Thank you, Dr. Srinivasu. I feel you could not have done a better job than what I expected, because you rightly highlighted the fact that the ISA guidelines are as good or maybe even better than WFSA guidelines or the ASA guidelines that you mentioned in your talk. The NBM protocols, I feel, especially in pediatric age groups, have really changed in the last few years.
Yes.
And unfortunately, even now, sometimes we do see some pediatric patients coming up with being fasted for the last 10 hours or 12 hours. So especially those pediatric anesthesiologists should be made aware, or the surgeons made aware, that the patient 4 to 6 hours of fasting is more than enough, and you will not have a crying baby being brought into the operation theatre, as is so commonly seen in private practice. Thank you, sir. Over to the next speaker, Dr. Pratibha Kane, madam. I feel that I have no reason to give her any introduction. We all know her so well. As Dr. Bala also mentioned, anything medical legal, and she's the first person who comes to our mind. And believe me, this booklet that we have come out with could not have been possible without her dedicated efforts towards the cause. Thank you, madam. In front of public, I would like to acknowledge that, and I hand it over to you, madam, please.
Thank you very much, Dr. Pankaj, and for giving me this invitation to actually contribute towards the booklet, and also today this invitation to present informed consents in anesthesia practice. Let us decode the complexities of the legal and the ethical frameworks. So consent in healthcare is a permission given or an agreement made voluntarily by a competent patient for any medical intervention. Taking a valid consent is the responsibility of the doctor for any examination, investigation, or treatment. Now, this concept seems very simple, but executing it is really difficult in the Indian scenario. We are moving from a paternalistic approach to respect for the patient's right to autonomy, which means that the patient has the right to decide what is to happen to his or her body. And this has been endorsed very clearly by the Supreme Court in Samira Kohli versus Dr. Prabha Manchanda case in 2008. So, an improper consent is negligence under the CPA, an assault or criminal force in criminal cases, and the NMC regulations call it misconduct. So we need to get it correct. So the first is that we need a mandatory separate anesthesia consent. This is really a no-brainer because the risks of anesthesia are distinct from the surgical risks, and more important, that the patients are not aware of this additional risk. So how to conform with the ethical requirements, how to respect the patient's right to autonomy. So this is only possible through dialogue and discussion. So we have to give adequate information, we have to check for understanding, answer questions and clear their doubts and fears, and finally come to an agreement, which is now called the shared decision making, which is so important. Basically, it means that we have to help the patient make an informed choice. The legal requirements are basically two, which are given in the Indian Contract Act. That is, we need a competent patient and the consent should be voluntarily or freely given. So an adult competent patient is more than 18. He is of sane mind. He is not under the influence of alcohol or drugs. And he is the person who must give consent. It cannot be the father-in-law, mother-in-law. The relative signature is only an additional security. An incompetent patient needs a proxy consent from parents, guardians, and near relatives. Today, it is important to understand or to find out if the patient has a living will which is registered, because this has to be taken into consideration for making decisions. A child less than 18 is not competent to consent. The Aadhaar card must be checked for age confirmation. Assent should be attempted, but only with the permission of parents, because we really don't know how much the parents have told the child. So age-appropriate information can be given about what to expect. And then a signature can be taken from a child who is 12 to 17, but a parental signature or a parental consent is absolutely essential. One parent is enough. Now, MTP in 15 to 17-year-olds has become a really big medical legal problem. A parent has to give consent. The child cannot give consent on her own. And the POSCO Act applies whether the pregnancy is from consensual sex or from rape. So the police have to be informed. Now, how to conform with the requirement of voluntary or free consent? So the patient needs information. So we need to give it in a language which the patient understands. We must avoid medical jargon. If the patient is a foreigner, please add the name of the interpreter in your consent form. Then explain the details about anesthesia, including who will administer it, the benefits, and of course, the risks. Treatment options need to be discussed, especially for regional anesthesia or for a block, because there is some chance that they may fail or they may be inadequate. And plan B or GA, it is better to obtain consent for both. And we need to document the information that has been given. Now, this is very well done today's age with leaflets, videos, websites, and patients are accepting it for patient education. Disclosure of risks is really a gray area, and we have to document whatever risks that we have explained. So common risks, they say more than 10% have to be disclosed, but there is nothing like a percentage. The legal precedent actually comes from in India from Samira Kohli, where the Supreme Court has actually prescribed a real consent, which means that remote risks need not be explained. But today, more and more case law is coming up where the patients are saying that these risks have not been disclosed. So material risks or something which the patient would want to know, we have to disclose truthfully. For example, will I die? Or will I wake up in the middle of surgery? These doubts and fears need to be specifically disclosed and also mentioned in the consent. We need to actually, especially in private practice, need to tell the patient that ICU is not available, or if any complication happens, then this is the nearest ICU where we will take you. Even similarly with the blood bank, which is the nearest blood bank in case you are expecting blood loss, and it is being accepted by the courts that you have told the patient that you will need to go and fetch blood from this blood bank. Also, post-operative care. Who is going to be on the floor? If suppose you have left for a conference, who is going to manage your PDPH, or who is your locum, needs to be clarified in your consent, and you can actually introduce your locum or your team, which makes the patient really more comfortable. Now, by the time the patient has all this information, the patient may have some doubts, fears, and concerns. So we need to clarify those in some discussion. We cannot coerce or use our undue influence. That means force anybody to undergo the treatment that we want or to give guarantees for a cure. So we have to come to some agreement, which is again called the shared decision making. This is the big thing in consent today. And the last formality is authentication of the consent, which is an agreement which is signed by the patient. The doctor's signature today is required because our consents are looking more and more like a contract. And this is the SNDT format. That means it's a sign, the name, the date, and the time. This is very important in case there is any conflict later. So a patient has the right to withdraw his consent at any point before the procedure. Sometimes the patient may have a very strong refusal. So we have to document that refusal, and in that document, we must clearly state that we have explained the risk of refusing the procedure. If by any chance this is a very critical treatment which is required, for example, a Jehovah's Witness undergoing Whipple surgery and he doesn't want blood transfusion, you have to take help of experts, involve senior colleagues, surgeon, physician, medical director, owner. And if there are any strange demands which you cannot comply with, it is better that you withdraw. Okay. In an emergency, consent is not required. We need to operate in good faith to save life and limb, to stabilize, and to prevent deterioration. Just go ahead without consent. There are the BNS Section 30, which is an act done in good faith for the benefit of the person without consent, will protect you. It is very clear from Parmanand Katara's public interest litigation that human life is more important than legal formalities. So do not wait for relatives, though all effort must be made to locate the relatives. Let's look at all the modes of consent that we have. We have an implied consent, an express consent, a written consent, and a video consent. So implied consent, which is required, we don't take a consent to put an IV or put monitors. Express consent, which is verbal, is something that UK uses, and it is all legal. You can, ask the patient, do you need a epidural, or are you having so much pain, and the patient actually verbally says, I need an epidural. So that is accepted in the UK. But in our litigious society, implied consent and express consent is very difficult to prove after 5 years or 10 years. And written consent and video consent are the answer to that. So let's look at those in detail. See, no law in India requires a written consent preoperatively. It is recommended to safeguard the doctor. So a written consent statutory requirement is only in these four places. One is the MTP Act, the PCPNDT Act, the Transplantation of Human Organs Act, and the clinical trials. In the Transplant Act, a written consent of the relatives for organ donation is required even if the patient has signed a pledge for transplantation, and a video consent has been recommended. Similarly, in clinical trials, you have to disclose all the risks, and we have to disclose who is going to take responsibility for the compensation. And here also, video consent is recommended. The consent form, okay, the consent form should not be totally printed. The specific risks that you have explained must be there on the consent form, and you have to show some obvious individualization, because there came a case law, this Vinod Khanna versus R.J. Stone, where the judge said that the pre-printed consent forms are unfair trade practice. Though this order banning pre-printed forms is currently stayed by the Supreme Court, but as far as possible, try to individualize your consent form. So special consents can be taken for invasive monitoring, or you can add it in your a high-risk consent. Similarly, for blood transfusion, now most of the times we are taking a separate form which states the risk of HIV, HCV, blood infections which are transmitted. You need separate specific consent for publishing and for live telecasts, and the patient has to specifically say that they understand that their name or their face is going to be, telecast. Now, a high-risk consent. Now, the consent which we call high-risk consent must conform to the situation. We can't just write high-risk consent and leave it at that. The consent must mention the comorbidities. It must mention what the vital status is at the time of taking the high-risk consent, the name of the patient's relatives who are going to take the decision, living will if it is registered, details of counseling, whatever has been done, the intraoperative risk, the critical risks like cardiac failure, respiratory failure, need for ICU and ventilation. Now, the legal status of a death on table consent is actually, it is considered very poor in law. That is because we are now asking the patient to sign his life away, okay? So we have to take consent for that 2% chance of getting better rather than the 90% chance of death. So we have to always have some kind of hope instilled in our risk. So if there is 100% chance of death, then it's best you don't even touch this patient. So, and in your high-risk patient consent, involve all treating consultants to corroborate that high risk. This is your best kind of bet. A video consent is the best evidence for having taken a consent and also for the counseling that has got done. Now, the telemedicine practice guidelines of 15th of 2020 have given us a clear mandate of how to do a recording of any consultation. So before starting the recording, either on the recording or a physical, form like the one it is over here, you have to take the consent for recording and for its release. Okay, so we have to say that this recording is for recording of our consent or your consent, and it is going to be used in case of any conflict. And we can say that you need some script which is ready. Don't just go, because it can act like a double-edged sword if we get some of the questions or answers wrong. So some preparation is required. And when you are kind of recording, always have the patient with at least 2 relatives in the video. This is to prevent allegation of any sexual intent. Today, there is a lot of this trying to implicate doctors in some kind of a sexual intent. Infrastructure to record and save this digital data. Please understand that everything that you record of the patient becomes a digital data. And today we have the DPDP Act of 2023. So your patient privacy and confidentiality has to be ensured. So you just cannot leave it lying around. It has to be secure, and you are responsible for any breach of this digital data. So there are many barriers to informed consent. Like I said, it's very difficult to conform to all the ethical and legal requirements. That is because of our time constraint. So we have a limited time in the preoperative counseling. Sometimes we just have a brief preoperative visit. The surgeon does put pressure not to disclose too many risks. And we have some systemic issues. It's unsupported system. 24/7 admissions are going on. Daycare, surgeries, everybody wants to fast track the processes. And there is really very little time. And not only we are suffering, but even the patients are dissatisfied. So let's look at what are the world's best practices for consent. So the UK before was not disclosing any remote risks. So the doctors would say that there's no need to disclose remote risks. But after the Montgomery 2017 judgment, material risks have to be disclosed. So material risk is whatever the patient wants to know. So the patient may want to know about nausea, vomiting, pain, but she may also want to know about options. And what if I don't do this surgery? So all those have to be addressed, okay? US is mandating full disclosure. Everything in the book has to be thrown at the patient, which is, which is actually very, very safe for the doctors. France has put up a legislation in 1994, and what it says is that the consent process starts 2 days prior to the planned surgery for an unhurried, uncoerced decision to allow time to obtain more information if required and to review the decisions taken. This, of course, is for planned surgery. In emergency surgery, this doesn't apply at all. But this is also very, very safe for doctors. So let me conclude by saying that as far as possible, we must try to get a patient-centric consent, which is really a true shield for litigation, and documentation of the details of the dialogue and discussion is the only thing that makes consent into a formidable defense. Now, whatever I have said just now has been integrated in this position statement of anesthesiologists, and I would recommend that everybody referred to this statement, which has been painstakingly put together. And I really thank Dr. Gupta for, his initiative. And thank you very much. Thank you.
Thank you, madam. That could not, that compiles the whole booklet, I feel, in short, why it is so important in private practice to have proper consent. Gone are the days where we have seen just blanket consent or blanket signatures being taken on the indoor sheets by various patients and their relatives. And I feel you have really brought out the intricate details as an absolute must in today's practice. You have to save your skin first. Even the idea of shared decision making that you mentioned is becoming very important in everyday practice by and by, because patients are becoming having more and more questions to ask. The Google and the internet gives them so much information.
Unless we do some discussion, or
Exactly.
ask if what are you, do you have? So I have this thing, because even I have very little time. So all I do is say that, do you have any questions to ask me?
Yeah.
And that really makes a difference, because sometimes there are some questions. And, addressing them is really our ethical requirement. But
Yeah.
quite a lot of times we do, do not really take
Yeah.
cognizance of that. But
And
more and more, like we are, patient autonomy is becoming so important that we have to somewhere show that there was a discussion. Even if you have 10 pages of consent and if the patient says, I didn't get time to read it or I didn't understand it, the consent really goes for a toss.
yes, thank you, madam. Thank you, madam. Really brought out the intricate details. And even you mentioned about plan A and plan B, which we have mentioned in the booklet. A surgeon will just tell the patient the anesthesia is going to give a block. But we all know there can be failure in blocks. So a plan B is an absolute must. Also for the higher risk patients, in case they have to be shifted, there is no ICU in the present setup. They have to be informed of the tertiary care centers that are available in the city and the attachment of this primary hospital to the
Yes.
tertiary care
It
center.
just makes, our life little more simpler.
Exactly.
And it will give you some kind of relief, that we have informed this. See, every patient need not be told, but there are some which are borderline, You don't know whether they're going to have complications, not going to have. But, being frank, being discussing all these things does definitely make a difference. And people like to trust you,
Yeah. Thank you, madam. Thanks a lot.
And
We had a wonderful discussion that it was. I'll come over to the next speaker, Dr. Mahesh Sinha, who requires no introduction again. He's just finished his term as the vice president. And now the Raipur conference, ISACON, this year is going to be under his aegis. And I feel we all know how soft-spoken and a thorough gentleman he has been. And his knowledge is really wonderful. If any of you have any issues about knowing anything, he's the first person you can definitely go to in case of any issues. Over to you, Dr. Mahesh Sinha. He'll be talking basically on mandatory monitoring and other standard requirements in operation theatre, which there are some controversies. I'm sure sir will bring them out. Over to you, sir.
Thank you, Pankaj, for so nice and humble submission. Thank you for giving the opportunity to address the August gathering across the country. So basically, monitoring standard requirement in the operation theatre. Basically, it can be said the repetition for most of the people, but it is go that we should go on doing revising things and get updated. Yes.
Please, sir.
Yeah. So there are recommendation by in the booklet about these things also. What is equipment you require in the operation theatre, and there are certain like highly recommended pipe gas supply, continuous supply in oxygen cylinder gas, because there have been cases also where this has become the biggest issue. There is no oxygen in the hospital. Anesthesia machine or the workstation with hypoxic guard safety system, nitrous oxide or air supply either by pipeline or cylinder. Either of this has to be available, because we cannot give anesthesia only using the oxygen. One emergency oxygen cylinder mounted on anesthesia machine, and one more important thing, the necessary spanner need to be there, so you can open it. Otherwise, you are looking for the spanner where it is. Tilting OT table in case of emergencies to maneuver the table. Working suction machine with all connections, suction tubings and catheters of appropriate size according to the age of the patient. And the ambu bag, the ultimate savior in many situations. Multi-parameter monitors, pulse oximeter, ECG, NIBP, these have become just a routine for anywhere, whether it is a small nursing home or a corporate hospital. It doesn't has to be justified. Without presence of this, you are doing any anesthesia, whether it is regional or general. You cannot defend yourself if something goes wrong. The use of closed circuit is mandatory for all laparoscopic surgeries. It is a different domain, has come although quite long time. So it requires monitoring of ETCO2 also in such patients, because If you don't have now EtCO2 and you are using carbon dioxide and doing these laparoscopic surgeries, you can be in trouble. Temperature monitoring is recommended particularly for children and geriatric patients. Although we don't have regular monitoring systems in our monitors, but the inclusion of this is a good suggestion. And defibrillator is actually mandatory, at least in every hospital should have a defibrillator. And during the surgery, it should be placed near the operation theater only. Working laryngoscopes, air blades, Miller's blade for pediatric patients. All the airways, we know, oral, nasal, distributing steroids, Wuji's, adult and pediatric, McGill's forceps, endotracheal tube, all sizes, supraglottic airway devices, as many as you can have, appropriate sizes, peripheral venous cannula, depending upon what type and what age group of the patients you're dealing with. Then the spinal needle also accordingly, all the different sizes. Epidural set, 16, 18 is the common sizes. You get the pediatric also. So if you are working in the pediatric area, you require that smaller sizes. Three-way connectors, extension tubings of different lengths, IV sets, micro sets, blood transfusion sets, scissors, tapes, ampoule cutter. These small things, but they are very important when you need them. Torch, thermometer, syringe pump, and infusion pumps have also become a regular armamentarium in our specialty, with particularly with going the IV way, continuous IV anesthesia, and then the nebulization if the need arises. Particular different area, you should have something like intubating Wuji's, LMA already mentioned, McCoy blade, precothyroidotomy set can be severe, and even 14-16 gas needle can also save in emergency. Recommended is intubating LMA, video laryngoscope, fiber optic intubating scope. Although these are the things which are not available in smaller setups, but before that the smaller emergency devices should be available. Then we come to the monitoring standards. The highly recommended is the age-old from where we started. Clinical observation is the most paramount. It's not like that monitor is there, so somebody is monitoring. No, you have to monitor the monitor. Monitor cannot monitor itself. It may blow the alarm or something to waken up, but you have to see whether it is appropriate or not. Pulse rate and quality, tissue oxygenation, perfusion, respiratory rate, breathing system, bag movement is also. Although now most of the machines have ventilator, so we have lost the feel of the bag. Actually, the feel of the compressing the bag could tell a lot of many things. Observation of the breath sounds. Similarly, the heart sounds, particularly in smaller pediatric patients, precordial esophageal scope as required. Signals and alarm of the monitors. Usually what happens many times when it is beeping repeatedly, we should try to find out the reason, not making it muted. Then continuous use of pulse oximetry, intermittent non-resistive blood pressure monitoring, carbon dioxide detector for patient undergoing intubation. Recommended inspired oxygen concentration monitor device to prevent delivery of hypoxic mixture. These are the now high-end things which are now coming with the newer machines. Disconnect alarm is mandatory when mechanical ventilator is being used. Continuous use of ECG, intermittent temperature monitoring, peripheral neuromuscular monitor when we are using muscle relaxation, particularly continuous waveform capnography of patient going general anesthesia and deep sedation. Suggested continuous measurement of inspired and expired gas volumes. Similarly, inspired and expired inhalation anesthetic concentrations, and arterial blood pressure. It is a mandatory in certain types of the cases where the major, supramajor cases, or if the cardiac surgery is going on, or even in a cardiology setup where a stenting or angiography is going on. Continuous electronic temperature monitoring, urine output. Urine output is an age-old system, but we do it not monitor it frequently. So regularly monitoring is also very important. Processed ECG, EEG like BIS is also coming in a big way. And ultimately, this has come to the, in our duty also, we are also part of this WHO surgical safety checklist. And we need to, particularly in the NABH Institute, it is mandatory, but these are gradually spreading because numbers of NABH accredited institutes are also increasing. So we have to be learning about, and we must know about the 3 points during the surgery. This has to be all the filled before induction of anesthesia, before skin incision, and before patient leaves the operation theatre. These points, and that has reduced the complications during an surgery a lot. And this, we should be proud that this surgical safety checklist has been based on the recommendation of one Indian origin doctor, Dr. Atul Gawande, who is a very prolific and very good writer also. He's written many books related to medical field. Thank you very much.
Thank you, sir. That was really great. And the idea was to highlight all that is important in today's practice. And it's, I really liked some of the words like monitoring the monitors, because even when I did my post-graduation, there were no monitors, and our hand used to be always on the pulse. And that's how we trained up. And it was after 3-4 years of practice that we got monitors to monitor patients. And of course, a call out of the WHO checklist is very important, I believe, today. Before every operation, we should have a call out in the operation theater. It makes and reduces our complications rate in a very big way. Over to the next speaker now. Thank you, Dr. Mahesh Sinha, sir. That was great. Dr. Tushar Choksi again requires no introduction. Dr. Bala Venkatwale has mentioned our world famous person from India, the infographics man, the Tiva man. He is one of the most dedicated practitioners I have come across, and he's always been ahead of his times. And I have really seen him, his infographics. I feel he's going to be the infographics man of the world very soon now. Over to you, Dr. Tushar Choksi. Great to hear from you.
Yeah, thank you, Dr. Pankaj Bhai. And good evening to all. And good evening to all my prior anesthesiologists. It is just a trailer. It is just a revision of all the anesthesia drugs which you are using in your theater. So, can you see another slide?
Yes. Yes.
Okay. Now, what are the drugs invented in anesthesia till now? There are 73 drugs are invested under the banner of all IV anesthetics, local anesthetics, inhalation anesthesia, anesthetics, relaxant, muscle relaxant, and other types of opioid and gases, and newly introduced drugs in 2025. So out of these, 55 drugs are in the pipeline and we are using, and others are just historical significance. So mainly we are classifying our anesthesia drugs in 3 groups, mainly induction agents, volatile agents, and local agents. So if you see the actions of the anesthesia drugs in the body, whatever the drugs you are using, there are 6 actions of these anesthesia drugs. They are mainly sedations, analgesia, hypnosis, amnesia, relaxation, and autonomic stability. Whatever the drugs you are using in your theater, outside theater, out of that 6 actions, they will be having their own actions. So what are the volatile anesthetics? Volatile anesthetics are volatile used to induce by lungs and for the maintaining the general anesthesia. What are the common agents? Isoflurane, sevoflurane, desflurane, halothane, and nitrous oxide. Out of this, in our theater, we are mainly using now sevoflurane because all these are historical purpose. So advantage of this: precise control, rapid onset, minimal metabolism, easy administration. But there are more disadvantage after Corona time and before Corona time also I considered, because it gives dose-dependent hypotension, respiratory depression, malignant hyperthermia risk, which is more prevalent than IV agents, and environmental pollution. That is why the people are switching over to now IV agents. So these are all the infographics about all these gases and inhalation agents, something like nitrous oxide. I will go just for the 30 seconds or this on this my screen. Sevoflurane. I will talk about this sevoflurane. Sevoflurane is used by all the anesthesiologists in the country which are practicing as a private practitioner. It is a very, very safe anesthesiologist as a volatile agent. Isoflurane. Still, I'm using isoflurane in some of my private nursing home because they don't have sevoflurane vaporizer. So I have to use it. Halothane, when I was practicing in the initial 20 years period, then exclusively I was using this halothane. It was excellent, but because of the hepatotoxicity, it was just vanished away. Enflurane and desflurane, I never used it, but in some of the part of the country, still they are using. Xenon. Xenon is a anesthetic of the future. I talk about this xenon as a most perfect and ideal anesthetic agent. It's a agent of the future anesthesia program, and xenon has virtually no side effect. It is also given in the space anesthesia. So what is the mechanism of the action of the inhalation anesthetics? When they are taken, introduced in the body by the lungs, then it enhances the inhibitory neurotransmission. It inhibits the NMDA receptors, increases the unconsciousness, induces the analgesia. It causes muscle relaxations in the high dose. It decreases the neuronal excitability. It disrupts the lipid membranes and after synaptic transmission. And their metabolism also with the lungs only by exhalation. And they have a minimal metabolism. They also influence the solubility, influence of the alveolar ventilation. So inhalation agent, they are very safe sometimes, but not in all patients when we are doing in our practice. Understanding the complex risks of the inhalation anesthetics are they are nephrotoxic or hepatotoxic. The main drawback is they causes malignant hyperthermia. So that is why people are now switching over from inhalation anesthetic to the intravenous agents. It is dose dependent effects because if you give Bormack value of the inhalation agent, then it gives the hypotension, bradycardia, sometimes even I had seen the death even that patient. And most important that complication occurs during the inhalation anesthesia is nausea and cognitive dysfunctions. Come to the intravenous anesthetics. Intravenous anesthetics are faster onset, rapidly induces the anesthesia. Even quickly, within 30 seconds when you give IV, it gives the anesthesia. Fewer airway irritations, minimal respiratory complication. It reduces the nausea and vomiting, lowers the risk of postoperative nausea, smoother induction. I don't use any inhalation agents and I'm very happy since last 10 years in my private practice because of the IV agent and in my practice TCI TIVA. Ideal for the intubations, lower environmental pollution. Which are the agents we are using? Propofol, thiopental, ketamine, diazepam, dexmedetomidine, etomidate, methoxytol, midazolam, lorazepam, and chlorhydrate. Out of this, propofol, ketamine, dexmedetomidine, and little bit midazolam, which we are using in our operation theater. And I say about propofol, it is a very, very commonly used anesthetic agent. Ketamine is a very popular anesthesia agent in the private practitioner forum, private practitioner anesthesiologist. Dexmedetomidine came first, then vanished away, then again came just 10 years back. It's a sedative with the analgesic property. People are underutilizing these drugs. I will tell you that you must use these drugs judiciously. Don't fear using these drugs. And midazolam. Now, midazolam is a ICU drugs. I don't recommend to use midazolam in our OT now. Something about propofol. Propofol is most commonly used in TCI, TIVA, and even induction and maintenance. So everybody knows about the propofol now. Etomidate. Etomidate is a cardiostable drug. It is just reserved drug for the hemodynamic unstable patients. Ketamine. Ketamine is my popular drug. I am using day in and out this ketamine in my private practice at the end of the surgery, before the surgery. And you know the beauty of this ketamine. Ketamine can be given by any route of the pharmacopoeia which is mentioned in book. And it can be mixed with any solution about any even pints or any combination like propofol, dexmedetomidine, fentanyl, midazolam, diazepam, or even newer drugs. So ketamine must be in our armamentarium. Then dexmedetomidine. It's a agonist of the alpha-2 adrenergic receptors. See, these drugs, I'm getting questions since last 10 years that, sir, when we are using these drugs, there is more hypotension and bradycardia. But believe me, I had never seen that patient died because of the dexmedetomidine. But if you are not aware of this using these drugs, then don't use it. Once you read these drugs, then you will be in the loving to these drugs, because it's a wonderful drug and most ideal anesthetic agents, because it gives the analgesia anesthesia in all sorts of the stages of the anesthesia. Sodium thiopental, we were, see, about the one word about sodium thiopental, when it was invented in 1934, it has changed the anesthesia practice. Those who are using, I have used for 10 years in my practice, but except these drugs, not a single drugs were available. Midazolam, now after Corona, this drug is now ICU drugs, because in Corona period started using these drugs. I know as far as in my area, midazolam is now ICU drug. Some about the local anesthetics. Which are the local anesthetics are available? See, some local anesthetics are historical use, some are long acting, some are short acting. So lidocaine, bupivacaine, ropivacaine, levobupivacaine, all these drugs are in our pipeline. But mepivacaine, pilocaine, chlorprocaine, tetracaine, bupivacaine, cocaine, procaine, articaine, etidocaine, hexaclane, and butamben. These are all the drugs are historical. Either they are used outside the anesthesia armamentarium or as a topical use. But they are classified as a amide or esters. Amides are what? Tetracaine, chloroprocaine, prilocaine. And amides are lidocaine, bupivacaine, ropivacaine, levobupivacaine, and mepivacaine. What is the difference between these two drugs? These two drugs, either they are liver metabolized amide anesthetics, and another esters are metabolized in plasma. And this amide anesthetics, which we are using, bupivacaine, then lidocaine, everything is lower allergy risk. And other ester anesthetics are having a higher allergy risk. These are the two main difference between these two drugs. And mechanism of action is, when we are giving these drugs in the body, then they act as, they block the voltage gate sodium channel, prevent sodium influx, it inhibit action potential propagation. So that is why they give loss of sensations, and preferential effects are on the small and large fibers. And these fibers are influenced by the lipid solubility of the drug, PK, and protein binding. And what are the main effect of these local anesthetics? They give procedural analgesia. We are using for the pain management, in surgical anesthesia, in reversible anesthesia, sodium channel blockade. Nowadays, under sonography guided block, we can do from top to bottom any head to toe surgery under blocks anesthesia. So that is the beauty of local anesthetics now. Some of the local anesthetics like lidocaine. Lidocaine, I consider it as a very magic drug. I started my practice since last 35 years. These drugs were available, and without single day, it is like that the day starts with my lidocaine and day ends with my lidocaine. It's a magic drug. It can be given IV also. Bupivacaine. Mainly we are using bupivacaine in our spinal anesthesia or in epidural anesthesia. Then mepivacaine, levobupivacaine, and ropivacaine have its own indications. The difference between this bupivacaine and ropivacaine does not give much relaxation, so it is reserved for the anal canal surgery. Now, some words about the local anesthesia toxicity. When you have, I have never seen local anesthesia systemic toxicity in my lifetime, so I am fortunate that part. But you must have lipid emulsion therapy in your OT when you are using frequently local anesthetics in your, some opioids in anesthesia. Which are the opioids we are using? From morphine to ramifentanil. Morphine, fentanyl, sofentanil, ramifentanil, and some sort of meperidine, hydromorphone, and oxycodone, they are used in the foreign countries. So nowadays, fentanyl is less used and ramifentanil is coming in the market. Now, for ramifentanil, it is an ultra short acting opioid for the quick procedure. For using this, I will say about 1 minute about this agent. When you are using ramifentanil, you must use some TCI pump. Without TCI pump, I will never recommend to use these drugs, even in infusion or in a simple syringe pump, because it is a very fast acting drug. And if you close these drugs, then immediately it vanished out from the body. And it is always to be used in the TCI TIVA regime. So this is morphine. Fentanyl, I have specifically put in the black and white because it is a very, very vanished out drug. Then remifentanil. Remifentanil, we have prepared from the IOTA how to use it, this remifentanil in the pump. Nowadays, I will recommend also for the pump, don't use second generation pump, third generation pump in the form of Eleveld model. It is now recommended for the remifentanil, TCI Tiva, but Minto is also for the remifentanil. But nowadays, in all over the world, the Eleveld model is used. Some neuromuscular blocking agent. There are two types, depolarizing, non-depolarizing. Depolarizing, succinylcholine. See, people have switched over from succinylcholine to some other rocuronium and that. But in today, when we are old anesthesiologists, we are still using succinylcholine and we are very prone to use every day. For intubating, I'm always using succinylcholine. I'm very used to these drugs. So for quicker onset and short duration suitable for the rapid intubation, I always use depolarizing agent, that is succinylcholine. Other non-depolarizing agents are rocuronium, vecuronium, pancuronium, atracurium, cis-atracurium, mivacurium, doxacurium, metocurium, and others. Galamine. About galamine, I have used this flaxidil in 2 years of my residency, and that was called as a trade name was flaxidil. It was the only available anesthetic muscle relaxant at that time before pancuronium came in the market. So suxamethinium. I think this drug, if you are have a chance, then use this drug. I never say that now you don't use. Atracurium. Atracurium now people are not using much, so it have shifted with the cis-atracurium, very safe drug in kidney and renal disease. Vecuronium. Vecuronium coming in the market now rapidly because now reversal agent, Sugamadex, it came in the market. And vecuronium Sugamadex combination is now accepted by so many anesthesiologists in India. So in private practice, this combinations is coming up very nicely. Even rocuronium. Rocuronium is very costly drug in the market, but rocuronium is always to be reversed by both the way, neostigmine and Sugamadex. But rocuronium and Sugamadex combination is good. Some reversal agent, neostigmine, Sugamadex, flumazenil, naloxone, dantrolene, and doxapram. Neostigmine we are using in our day-to-day practice, but Sugamadex, at least 20 to 30% market of the neostigmine is taken over by the Sugamadex. This is a new agent, reversal agent. In these two words is that it only reverses the vecuronium and rocuronium, and it does not require to add any atropine or glycopyrrolate, but it is still costly drug. Naloxone. Naloxone is the opioid reversal agent, but this is not frequently available. There is a kit available for that. It can be given intranasally also. Nasal spray is approved in 2015. Flumazenil is a benzodiazepine reversal. It is also available in the market, but not commonly it is used. Even dantrolene. Dantrolene, as far as my knowledge is concerned, out of India, only 20 to 30 hospitals have dantrolene stock. If one patient got malignant hyperthermia, then the cost to reverse that patient for using dantrolene is more than 2 lakhs rupees. Some adjuvant drugs are antiemetics, ondansetron, metoclopropamide, anticholinergics are atropine, glycopyrrolate, and others are magnesium sulfate, dexamethasone, amisulpride. Amisulpride came in the market as a post-operative nausea vomiting reversal, and it is coming up in place of the ondansetron. Others are for the NSAIDs, paracetamol and diclofenac. And anesthesiologists, as a beta blocker, they are now choosing the esmolol. So glycopyrrolate, atropine, you know. Dexamethasone is a universal friend. I know each and every anesthetist in the country, as a private practitioner, they are using this dexamethasone in their pre-medications. Even magnesium sulfate is also coming. I called it as a friend, philosopher, and guide for the anesthesiologist. You must use this agent very judiciously. It is a very good agent. Ondansetron, usually all the anesthetists are giving pre-medication with the ondansetron. Paracetamol and diclofenac sodium, these two agents, I will tell about, not detail, but the rule of the thumb, when you are using paracetamol and diclofenac sodium, always give before the surgical incision is there. Once the surgical incision is there, and then if you give diclofenac sodium or paracetamol, then then the effect is not that because PGE2 inhibitors are released. Esmolol. Esmolol is my very favorite drug. I use in every day 2-3 bulbs because it gives very good result for the laparoscopic surgery, ENT surgery, and my neurosurgery patients. Very rapid onset toxin. Hypo is more, Brady is less, and it goes central analgesia. It has got a opioid sparing adjuvants. I think this agent is underestimated. Some of the newer drugs came in the markets are remimazolam, amisulpride I told you, and ciprofol. Remimazolam, ciprofol is not available in our country, and amisulpride is in the name of from La Renon. This Sultaren is available. So this is remimazolam. Remimazolam it's a benzodiazepine, but some of the properties of the opioid is there. It is very costly drug. It is not available in India, only in India. Otherwise, all the countries in the world, they are having available this. When this available in India, then it will change the anesthesia practice like a propofol. This amisulpride is used in the, it is just a second choice for the post-operative nausea and vomiting. But I use frequently now these drugs in some of the indicated patients like gynec patients, then laparoscopic patients. So it is used in the 5 milligram single IV dose preoperatively for prevention of the PONV. And if the PONV is occurring, then you have to use 10 milligram single IV dose and available as a 5 milligram bulb. Now this ciprofol developed in the China, and it is the third phase of his study, and it is better than the propofol, which they are claiming. Now, other two drugs, they are coming in 2025. This neosaxitoxin, this is a long-acting local anesthetics with minimal toxicity. It was invented by the sea cultures. Methoxymetate, this is the new drugs coming in the market. So anesthesia consideration from obese patient, all type of patient, we have to consider with the dose, rate, and height, sex, tailor-made anesthesia. Even in renal disease, liver disease, we have to be very careful which drugs to be used in which patient. Some of the drugs, two drugs can act as antagonists, some drugs act as a synergistic effect, and some drugs has given the complications if we are using simultaneously. So in summary, after hearing this lecture, everybody used to pamper that I will use these drugs. But whenever you use any drugs in your armamentarium, you must have knowledge of this drug and when to use, how to use, right time, right dose, and in right patients. So tailor-made anesthesia with the right dose is very required. So thank you, guys. This is just a glimpse of my lecture.
Thank you, Dr. Tushar. You have really taken us into the future, and I was expecting this very much from you. I mean, all the drugs that you mentioned in the later half of your talk definitely will be mentioned and updated in our future guidelines, because some of them even we have not heard of. I'm sure all the committee members are laughing about it. But as I said, you are a man of the future, and I'm sure the future guidelines will update once they are available easily in the country. Thank you, Dr. Joshi. That was a wonderful talk, and you really spoke from what we wanted you to talk on. Thank you. There are various questions and answers questions which I feel we can. This is to Kane Madam. In case of no relative, which consent is to be taken if patient is to be operated under GA?
Patient is an adult, he can sign for his own surgery. So there is no question. You don't need relatives. A patient is adult and competent, he can give consent. If the patient is not competent, but he needs some emergency surgery, then you have to inform. Okay, so you have to inform the medical director, and you just, like I said, that you have to operate in good faith, and you have to do any emergency surgery. For the sake of a relative, do not forego any emergency surgery. If it is an adult and he can just sign for his own, there are so many young girls nowadays coming alone for cosmetic surgery. And it's really a problem because anything happens to them, we don't know what to do. And it is a serious problem. I mean, we like relatives to be around so that, post-operatively they'll look after. But they are coming alone with an Aadhaar card which says they are 19. And so there is no need to stop for that. Actually, relatives, I feel, are, we are Indian and we always, rely on relatives. But today, more and more, people are just living alone. And they don't want to tell their husband, they don't want to tell their parents. You can't stop them. Okay, autonomy. Now, please understand that we are in a different world altogether. They say they want their surgery done. There is no reason to call the relatives if they are in their sound mind, they are more than 18, and they are not under the influence of alcohol or drugs. There is no need for relatives. But if it's a major surgery, I'm telling you, this is an Indian mindset. But there is no reason to ask for relatives.
Madam, if something goes wrong with them, like
so that is our problem. They are not expecting anything to go wrong.
Whom to inform in that case?
I told you this question is I mean, in the consent format, we cannot wait or ask them to get somebody, okay? Because they are capable of, signing for their own surgery.
But just to add to that, our consent form has we also take some witnesses. The idea of the witness is so that there is a relative, preferably there with the patient.
A relative is not required
from the
legally.
consent.
Okay, let's just accept this, that more and more patients are going to come. So then, see, if you feel for some reason that in your setup, in case there's a complication, you cannot handle it or whatever. So you have different reasons for refusing, but the patient legally does not need a relative to go ahead for any surgery.
Dr. Pankaj.
Yes, sir.
Can we give 1 minute time?
After the questions are over, sir, if you don't mind, I'll just finish the questions, unless you want to talk something.
No, I want to ask one question.
Actually, the point
I'll
is
just finish the
about...
questions. I'll just finish the questions, sir, and then we will open the house for discussion. Madam, one more question to you. When some procedure is scheduled to be done under LA, is it better to take consent for GA also?
See, now this has to be discussed with the surgeon. Okay, I would always discuss this with the surgeon. Sometimes we are there as standby. Okay, so a standby anesthesiologist is expected to take care only of allergic thing, not to give anything. He is supposed to be there to take care of any problems during local anesthesia. Sedation is a different aspect. So if I am going to actively give something, I would not call it standby anesthetist. Okay. You have to, so in your consent, you will say, yeah, I am going to give sedation, or take consent that, yeah, if you cannot tolerate this local anesthesia, I am going to do this. Okay. So if the surgeon specifically says that, yeah, I don't want anything, just stand there in case patient has a thing, you can say that I'm standing by to take care of your complication. And, but once you are in it, it is very difficult not to give something, If the patient is kind of screaming in pain, that is not the time to say, I'm going to give some, analgesic. So I would always say that, yeah, SOS, I will give something.
So plan A, plan B is what is basically mentioned.
All this 5-minute procedure, local procedure, and you have it. So I'm very clear, if I'm going to be there, then I have to do whatever is beneficial for the patient. And I will take the consent in that format. Okay. So very clear with the surgeon. Otherwise, I tell the surgeon, I'm not coming. I'm not sending my resident also.
So better to take consent for both the things, madam. When
yes,
it depends on what what you want to do.
Yeah. Next question again to Madam. If orthosurgeon himself is giving spinal and short anesthesia, what are the legal implications?
I didn't get that, sorry.
If the orthosurgeon is himself giving spinal and GA, what are the legal implications?
Why are you worried about it? You don't stand in that theater.
Yes.
Yeah.
Don't
And
worry
definitely-
about hypothetical things, or if these things are really happening, you should stay far away from that theater. That is what my thing is.
Pankaj, you
Do
do
not,
surgery.
do
important-
not now, see, we are not in a position to say what somebody else should do. We have to be very, very careful of what we are there. And if you see something like this, we are not in a position to take any objection. See, ideally means if in alternative reality, we are supposed to, by the NMC rules, we are supposed to complain. Do you have the guts to complain? No. So let's just leave it. Don't stand in that theater. Just get out.
Madam, what I'm preferring this webinar is for the gold standard of the practice, right? Standard
Yeah,
practice.
that's
So
right.
why to shortcut? Everybody is asking the questions about different mentality, but why they are not accepting the gold standard of the anesthesia practice?
That's right.
You have to take the consent. Whatever way, you will not be saved under
Because
the
it's
legal
for
process.
your own safety. I
It is
know,
when you are driving a car, then you are all these types of the safety you are doing. Then why not for the patient and yourself, at least yourself?
Correct. For
So my
yourself.
question to all the audience people is that why to go for the shortcuts in your anesthesia practice as a private practitioner?
And what other people are doing, it is now not even important, as long as you're not involved in as a a co-administrator or something like that. Just leave all these out, because it's just unnecessarily trouble for everybody. I can't believe first that people are yet in this day and age doing it.
This is like an example. When you are driving a car and then when you meet with an accident, then you will realize that what is the importance of the safety rules. So that is the way when you have the legal proceeding in your life for one case, whether you are given thousands of the cases or whatever,
That
but
is
then you will
true.
realize that whatever you are failing.
Madam, what is your call on now the nurses are being allowed to give anesthesia?
Sir, my call is that we are not involved with it. Okay, so this is going to come. Let us just face this, that more and more. Let's all be very, very clear that the more the AI and the more your monitoring improves and the AI is able to, actually give decisions, the one person with 5 nurses will be able to manage 5 cases, one consultant. That is what is happening world over. Okay, we can resist it as much as possible, but that is the trend. And I'm sorry to say, I've been to hospitals all over the world. One consultant is managing 4 in the US, Florida, 4 nurse anesthetists, because that is the economics. We cannot go against economics. That's unfortunate, but it is. So people will take chance on the patient's lives, and actually they are coming up with research which says that it's all right. So you have the same number of cases of complications where nurses are there, a same number where anesthetists are there. So if you start getting research like this, how are you going to, and see corporatization of hospitals, the economics has become so very important. Nobody wants to pay the anesthetist even what they are due. I don't know if you all are all experiencing this.
We will discuss that in the next webinar,
Yeah.
madam. Remuneration.
So, no. I mean, discounts. Everything is discounted, So this is going to come, whether we like it or not.
Madam, in
Question
that
to
case,
Dr.
the
Tushar
nurses
Choksi.
are trained for that, isn't it? As an anesthesia care, The nurses need to be trained accordingly in their courses.
They will be.
What is
They
it?
will be. And there will be a consultant on top of them.
Yeah,
Just
of
like
course.
we manage with
That is
residents.
not here in our nursing colleges as yet, isn't it? It's not that my hospital
No,
has got.
it'll take less time than we want.
It has been
Next.
it has been already published in the Gazette of India.
Yeah.
It'll take less time than we want.
Yeah. Next question to Dr. Tushar Choksi. How much potent remifentanil is as compared to fentanyl? Dr. Tushar? Is he around or is he left? No, Tushar, he had told, informed me he might be having an emergency, so probably he has left. But remifentanil, anyone in the group who used remifentanil?
So it is 1,000 times more potent than fentanyl.
Oh, great. Okay, now Chintala Kishan, you wanted to talk something. Dr. Chintala, and then Dr. Arun Mehra. Dr. Chintala, unmute yourself. There's one more question for you, madam. Legal validity of video consent.
It is very legal. It is very legal as long as you take consent. We normally have something which says that you are on video and you are being recorded. And this is something that you have to reiterate in your recording. You have to say that I am recording consent, and do you have, I mean, you're aware that we are recording it.
Dr. Arun Mehra, please unmute yourself.
Just one thing I wanted to ask Dr. Pratibha Kande, madam. There was a question for you regarding do we take GA consent for standby and all that? Well, yes, that's a very dicey subject. No doubt there can be no clear answer. Now, we all know that any local or regional or anything which we are giving, in which we are involved from the beginning, I mean, not that we are standby or something, can at any time have a requirement to be converted to GA. So isn't it better to take
That's what I said. That
consent
have
for
a plan
GA
B for all blocks and thing. It is better to say SOS GA. And see, the surgeons that you all are working with, we must be able to influence them to say that, yeah, this is how we are going to take the cut. Because once you're in the middle of thing, it's very bad. They say, nahi, te ata, he patient is under spinal, he's signing his consent. Looks not so good.
Anyone in the house can unmute themselves and ask any questions or give any comments. Someone has commented about some cesarean section, but I didn't understand that question. Madam, can you talk yourself? Dr. Sharma. Dr. Sumit Sharma. You can unmute yourself, 1+5. There's no name.
Meantime, can I ask what is really
Yes.
monitored anesthesia care? What does it really say? How do we go about that?
Is that question to
Madam,
Yes, madam.
you only, yeah, the type of
Yeah.
anesthesia.
Okay, so we have now two kinds of monitored anesthesia care. Why we are saying, see, we have replaced monitored anesthesia care. We have replaced it for standby. Okay, so standby is not a very, it's not a very respectable term. So what we have said that we will call it monitored anesthesia care, as they are doing in all the developed countries. They call it monitored anesthesia care, means we are monitoring and we will give whatever care is required to maintain those vitals. But there is monitored anesthesia care with sedation. Okay, so sometimes for endoscopy and all, we are already, so we have, so if you look at our consent form that we have prescribed in these things, you will see that we have actually mentioned each of these with its the risks and remote risks. I think it's as close to as we can get to a proper consent. Please go through them. We have mentioned MAC with sedation, and of course, all the regional anesthesia. What you need to do is you need to individualize it. Like I said, what you need to do is when you tick block, you please write, I have given a axillary block, or I have given a supraclavicular block. So we have left some things open, and the options, the fact, for everything we have written alternatives, just write GA over there and explain it, that there is a SOS GA option. In fact, I tell my patients that I'm going to give you regional, but if that doesn't work, we have all the GA, kind of ready. And because many times patients are very, very skeptical about undergoing surgery with just block. Spinal, they can understand because of maybe cesarean sections or whatever. But just block, patients are a little skeptic, and we say that, yes, we will give you whatever the injection here. If it doesn't work, we have, general anesthesia we can give you.
Dr. Chintala?
Yes. Madam, Pratibha Madam, good evening. Very nice explanation among all consent for the anesthesia. Among all, which consent is more important in the court of law? And one more thing is, in case of any under 17 or 18 age of the child, can we inform the police if nobody is there in case of accident? Is it valuable in the court of law?
Yes,
If
it
patient
becomes
dies?
an accident. The road traffic accidents have a different, you have to make it into a medical legal case. The police have to be informed. What I was talking about is MTP. Today, all pregnancies which are less than 18 years, and even if she says that I have had consensual sex, it is mandatory because it comes under the POCSO Act.
Dr. Tushar.
Tushar actually had to go for
Sir,
an
and
emergency.
which consent means we have only, we have prescribed one consent. So what we have done is we've given some information, general information, because
Madam,
then
you
now it
informed.
becomes like an education plus consent. Okay. So that is as close, I thought, as making it, an informative consent. See, if
Madam?
you don't read it and they don't have time to read it, that is another problem. But some people are actually sending this on mail. Okay, planned surgery. You are, you can do a telephonic, kind of a PAC, which is telephonic, and you can say that, yeah, finally we will decide, and this is the consent form. I would like you to read it. Okay, so these are some things that we can do to safeguard, because nowadays patients are coming up with, Google information and all. So we can do this, the previous day we can send surgeons having an anesthesia consent form on their table, which gives them information about anesthesia, and they can just say, go read this and the anesthetist will meet you. That is the best. That is something that I used to do when I was in private practice. My surgeon used to just hand over that consent form, which I have been using for the last 20 years. And they say, yeah, what about anesthesia? He said, yeah, this is the thing. And in my form, I used to have my telephone number on it. Okay. They can call me. I have never had a call. Believe me, everywhere I share my number, I have never had a call from the patient.
I do the same thing, madam. I do the same thing, madam. But I've had a lot of dental patients especially calling me up. Because there was a lot of...
dental is another slight problem.
Madam, on the table for tubectomy consent, husband is refused, but patient is accepted. Which is more valuable?
No, for tubectomy, the spouse's consent has to be there because it is going to affect his life as long as they are married. If they are not married and she says, I'm not married for whatever reason, it's very difficult to check also. But as long as she writes married, he's for tubectomy, for vasectomy, you have to have. For ART, you have to have the husband's signature.
Madam, one more question. Single anesthetist doing more case in same time. Medical legal view.
Don't do it. Unless you have, see, even many times, leaving a patient, suturing is being done and all. It's dangerous. I'm not saying, it's dangerous. And today's day, like Dr. Choksi said, one case can take away your life. It is 20 years of defending, and it's not worth it. What do you say, Dr. Pankaj?
Absolutely, absolutely.
It's not worth it.
Not worth it.
Those few extra, they will take your sleep away, they'll take your life away. It is so difficult in courts today, let me tell you. We have a terribly biased judiciary, which is not giving the doctors a chance. It is unfortunate, but this is what I'm seeing again.
Madam, your lifetime saving will go away by just one single case against you.
One police has to come. He will take away just in 1 minute. He will take at least 50,000 rupees from you.
So my mantra is very clear. My mantra is very clear. Work less, charge adequately, and don't run after cases. But even as a private practitioner,
at a time,
never.
Let's not even go there.
Exactly. Anyone in the audience wanting to give their suggestions or talks or give some comments or
there's somebody with a hand up.
Yeah, 1 plus 5. There's no name. 5. Only 1 plus.
1 plus 5.
Hello.
Please,
good evening, Dr. Kane madam. You said in.
I can't hear you. You're muted. You're muted.
Unmute yourself.
Unmute.
Hello. This is for Dr. Kane madam. You said in abroad countries, one consultant anesthetician, 4 or 5 assistant, they are doing the cases just to maintain economy of the hospital. But in such cases, if any mishap happens, so who is responsible? I think the consultant anesthetist will have to case. Anesthetist assistants are not legally.
No, she is not assistant. She is not assistant. Please understand, they have their training, and within their training, they can do anything. It's like Maharashtra. Okay, how are the the Ayurveda people able to do anesthesia? That is because they have said that we are trained, and they have proved that we are trained and we can give anesthesia. Okay, this is something. See, and their systems, okay, are in. See, today, if you tell your nurse, she's a qualified nurse, you tell your nurse, give this, and she gives something wrong, it is her responsibility. And it is the hospital's responsibility, because she comes as a vicarious liability of the hospital. So I am giving instructions to my trained nurse within their capacity. I cannot tell them, you load propofol and give. Okay? So within their capacity, if they are supposed to give an intramuscular diclofenac, which is in their capacity, they load up some adrenaline or atropine or whatever and give it. It is really not my responsibility. It becomes a vicarious liability of the hospital. Though, let me tell you, everything and they will point fingers at you. But see, abroad, what has happened is the insurance takes care of everything. They don't even have to go to court. They are saying that medical legal cases are like a scratch on my car. They are paying that kind of premium. They are not even involved in the defense. So we are in a different place. We have to be really very, very careful about. So let's not go to where what they are doing. They are under a different, and those nurse anesthetists, believe me, are trained really, really well. See, why will I take, suppose I'm a consultant there, why will I take the responsibility of doing 4 cases, okay, unless I know that they are adequately trained? So those things make a lot of difference. And let me tell you today, if you just open the paper, there is some problem with some doctor. And this is a fact. Everybody must keep safe practices. Don't allow patients to point finger as far as possible. I'm not saying, and have a defensive practice. This is absolutely from the bottom of my heart, I'm saying that you have to have a defensive practice. Doesn't matter, like abroad they say minimum investigation because the government is paying for their investigation. Today over here we are getting kind of you don't do a 2D echo. And the court is saying, why didn't you do 2D echo? Who are they? But we are not in a position to, you have to have a defensive practice. It doesn't matter. I see today is not the time to worry about whether the patient can afford. If he cannot afford, let him go to a government hospital. Let him manage things over there. I'm sorry to say this. I am very, very, I have compassion to the thing. Let me do it free, but, it is not worth our time, and saving money for a patient, unfortunately, is today's time. We just have to have a defensive practice, document everything 10 times, and, be safe.
Just to add to all that,
Madam,
if you realize
question.
in India, the practice was very disorganized maybe even 15, 20 years back. I feel in the last 8 years, in 2017, when the PPF thing started in ISA, now things are getting more and more streamlined. And maybe after 10 years or 15 years, what Madam mentioned is going on abroad, probably may go on in our country. But the most important thing today is having safe anesthesia practices, which we are again and again repeating in every webinar.
Don't take
Please,
chances.
no chances. Do work less, charge adequately, and have a
That
good
is
night's sleep.
Dr. Pankaj's mantra.
Mantra.
Yes.
Absolutely. Can I do it, madam?
Paying so much for the taxes, government taxes. Patient can easily afford. When they buy some TV or fridge, they are easily.
Madam, let's not go there. Let's not go there. It is not our concern.
Yeah,
It is not
affordability
our
I'm
concern.
talking about. They're paying whenever they buy something, they're paying so much taxes to the government. They accepted the taxes. So why not the doctor tells do something? At least they should go ahead because it is for their sake, not for our purpose.
Madam,
Exactly.
they will not pay for your anesthesia, for your laparotomy, but double they will pay for a facial. This is a fact of life.
Yes.
Exactly. I feel we have had a wonderful discussion. Anyone wanting to give more suggestions? Dr.
Madam, one
Srini?
more question. Are
Yeah.
Ayurvedic anesthetists are really allowed to give anesthesia as per
In Maharashtra, yes. In Maharashtra.
Maharashtra? Okay, okay, yeah. So they can give. They are doing surgeries also, laparoscopic surgery, everything they are doing. They are allowed to. Maybe.
See, that's what I'm saying. So just leave that out because we tried to, we tried to antagonize that. But I will tell you the fact of today is allopathic doctors are in a little bit of a soup. Better to be an Ayurveda or a thing, you will get a lot of support from the government. But for some reason or the other, there's a judicial bias against allopathy practitioner. There is a political, we are calling it vendetta, literally. Nobody is listening to us. In Supreme Court, we are going, nobody is listening to us.
I can
Good
say,
evening, madam. Good evening, madam.
Sir.
I am Dr. B.J. Rao speaking, madam. I
Yes.
would like to ask Pratibha madam and Pankaj sir. Sir, in your long practice, have you heard about any vicarious liability on any hospital has taken on the basis of have they stood for anesthetist?
Yes.
Have they stood for anesthetist?
No. See, if you are if you are employed by the hospital, okay, so you have, see, look at your contract, okay, look at your contract. If you come as a consultant, okay, they may not. But if you're employed by you are receiving a salary, they will have to. And now let me tell you one more thing. It all depends on what the patient is alleging. Today, all the lawyers will definitely put a vicarious liability on the hospital, but that does not mean they will take it away from you. They will put everybody's name, right to the medical director always gets involved. In corporate hospital, in the smaller hospitals, I think the medical director, but hospitals have various ways of squeezing out of these things. And but yes, hospitals have been kind of implicated, and they've had to pay. They've had to pay.
Yes. Just to
Madam,
add, just to add.
Just last question. Like the Ayurvedic surgeon is operating, should we give anesthesia? Like it's again.
See, the NMC had come up with these 2023 guidelines. Okay, and they've been actually revoked because of what they had written on generic drug. But one of the features which we had said let it be was that do not associate this. See, because NMC is our watchdog, and they have very clearly said do not associate with other practitioners.
I can see Dr. Ganesh Chendulkar, who also worked a lot towards the cause of our booklet. Are you around, Dr. Ganesh? Would you like to just give your comments?
Sir, I'm in a case, sir.
Oh, okay. We can hear you. You can just tell a hi to everyone.
Hi, Ganesh.
Hello, madam. Good evening, madam.
Good
It is
Good to
under
hear
the
you.
leadership of Kane, madam. We have been able to pull off a great job, and thanks to Dr. Pankaj sir's guidance and all other team members, they have done an excellent job.
Thank you.
Thank you so much.
Dr.
Thank you so much.
Thank you. Dr. Bharat Bhushan, our former GC member, I just saw him online. Are you there, Bharat? He must have left. I feel we can call it a day then, and if no more questions.
Dr. Mehra has got his hands up, so let's just finish with him.
Dr. Arun
Dr.
Mehra?
Mehra, you're not supposed to ask me so many questions.
Yeah, you are in the committee.
I just wanted to share one experience I had in relation to what you mentioned about the nurse anesthetists. Or, I mean, let us say, are we responsible for their actions? Now, what happened was, on one occasion, I was called to the CCU to put a patient on elective ventilation. My technician went along with me, and we had taken our laryngoscope and everything with us. And I told the nurse, the CCU nurse, please load succinylcholine. A minute later, I asked her, where's that succinylcholine I told you to load? She said, I've given it. Matha pakda, madam. Anyway, it was just about a minute or maybe 75 seconds. And
you have to be very
not worth it.
So immediately we intubated that patient. But the point is that after that, I was working in cardiac anesthesia at that time. And we made it a point in our department that nobody is going to even touch the anesthetic drugs except either the anesthetist or the anesthesia technician.
They don't know the implication.
No, that is a blanket. Anything kept on the Boyle's machine is not to be touched by anyone except the anesthesiologist. Even the nursing staff is not supposed to touch or even keep a loaded syringe or pick up any syringe from the Boyle's or the workstation. Very clear instructions.
There's one very interesting question. He said, are we supposed to do testing? Okay.
Okay.
All right. So let me just take that question. So for local anesthesia, there have been many case laws which said testing was not done. Okay. So for spinal anesthesia, should we actually test? So the answer is yes and no. For the simple reason is that in our practice we do not do it. Okay, so that is why the answer is no. But does it give accurate results? That is why no. Okay, so you can do a sensitivity test if you want to be, kind of legally correct, but that sensitivity test does not always give you the accurate result. Okay, so that is the reason. And suppose you do a test, okay, and it says that it is not whatever reactive, and then you give that drug. Especially this is more actually local anesthesia sensitivity is very, very rare, and that is why we don't do it. But ophthalmologists, okay, for some silly reason keep doing it. Okay, and so we have to kind of fight it on evidence base. And the evidence is that you can get false positives and false negatives. So that is your answer for this, for the fact that we need not do it. Because if you get a false positive, okay, you will avoid local anesthesia. And if you get a false negative, the local anesthesia, anyway, if you give the bigger drug, you can get a toxicity, which is very, very rare. And antibiotic giving a test dose is a good idea. Giving a test dose is a good idea. It looks good. Okay, it doesn't really save anything, but people are doing it for traditionally. So we just say that after test dose. Okay, it looks good on paper.
On paper.
Whether you do it, you don't do it. I personally, I do not give any antibiotic in the. I remember there was a consultant who said ki all these antibiotics the surgeons need. So they should be given in the ward and bring the patient. Okay. I am of the belief that if anything has to happen, let it happen in front of me. It happens in the ward, that patient will suffer. So I am more for the fact that even if it's a surgeon's cause, we are working in a team. I would like to give antibiotic, and I never put it in a drip because I really don't know what is causing the anaphylaxis. So if I'm giving it straight in front of me, I give a small test dose. I give the antibiotic loaded in a syringe. So I know that the next 5 minutes, if anything happens, it is because of the thing. After that, I'm giving 5, 6 different drugs. I don't know what has caused the thing. Is it the IV infusion? So I'm one person who doesn't use antibiotics in an infusion.
Dr. Zakir Patel, Dr. Sachin Pawar, anything to talk? Dr.
I
Divya
think
Gupta,
everybody is tired.
everybody is
No,
tired now.
very well
Anybody?
explained, madam, about all the points you have explained very well, madam.
Thank you, sir. Thank you.
Yeah.
Should we call it a day?
Okay, sir.
Ma'am, you are talking about this test and test of the drugs. I don't think there is any modern literature. Actually, this tradition is
No,
something.
we just have to see if we have to defend not doing. See, I'm just saying that if somebody, see, allegations can be put left, right, and center. Okay. Today, I'm reading the allegations which are being thrown at doctors. They're just anything. So we have to defend one line at a time. So we say, why is test dose not done? Then you have to say that it is not. It does not give. It can give a false positive or a false negative, and that is why in our practice we do not do it. Okay.
So we have
And
to
I have. Anybody has a problem? Any case comes up, please, kind of consult me. I can give you the literature on it, which you can attach to for your defense.
So you have to be drug specific. In antibiotic you must do, but for local anesthetic it is not.
Local anesthesia gives you false positives or false and a good anesthetic you will be foregoing, which you know that it doesn't have any real, it does not have, it's so rare, and you will be giving up a local anesthetic just because there's some redness over here.
Looking at all the discussion today, I feel in the next 2-3 months, I'll have one exclusive webinar only on medical legal issues. for the anesthesiologist. I feel
That
maybe
is-
after 2 to 3 months, I'll plan it that way.
That is the biggest issue facing the doctors.
Yeah,
No, no,
exactly.
today we are
Pankaj sir,
really in trouble, actually.
Yeah,
Very sad, but we are in trouble.
yeah.
Madam,
Thank you,
Pratibha madam,
everybody.
one small
And-
question, madam.
Yeah.
Madam, there was one legal this thing, when we are giving the antibiotic in theater, the presence of the surgeon was questioned. I mean, like whether the surgeon was available when I gave this drug. When anesthetist was asked in the court whether the surgeon was there right in front of you when you gave this thing and the patient had anaphylaxis.
Yes.
Is it mandatory that a surgeon should be available when I'm giving antibiotic?
See, remember one thing, okay? I am one person who will not induce any anesthesia unless the surgeon is at, like I have seen the surgeon. Okay, he can be sitting in the lounge, and I have been very, very strict about this, especially for major cases, that you please know, and you cannot be at the gate. I'm sorry. You come here, it takes me 2 minutes to put a tube. Literally 2 minutes.
Correct. You're
So
absolutely correct.
I mean, they hate me for it, but I just keep on. Sir, you just have to be safe. Everybody has to be around. And see that I don't know why that question has come, but today every detail is being, kind of questioned. And you have to just say that, yeah, this is our standard practice. Okay. So there are certain things on how to defend a medical legal case. So
Madam, this
you have to
is
say standard practice. You have to say antibiotic has to be given 20 minutes. The WHO says antibiotic has to be given within 1 hour of
1 hour.
surgery. Our protocol, my hospital's protocol. So all these things have to be brought into the case.
these few things are typically Indian protocols actually. Presence of surgeon. Nowhere in the world it is required.
Yeah.
No, but surgeons all over the world are keeping anesthetists hanging. I know that, and it's unfortunate.
Hello.
It looks like that. Like most of the judiciary is against anesthesiologists.
It is not anesthesiologists.
Against doctors.
Against doctors, yes.
And
Yes.
more about anesthetists, madam.
No,
Anything
and
happening in the
see,
theater. Anything
okay,
happening
now
in the
that we are
theater.
coming into this defense part, today they go to AI. They will go to Chat GPT and they will put down all these things and they will say, is there negligence?
Yes.
And Chat GPT will give them the answer.
Hopefully.
And today that Grotto has come, so that will to definitely give them 5 answers.
What is Grotto?
How the anesthetic? Yeah, there is some new thing
Grok.
Organ transplant.
It's supposed to be 3 times more informative than Gemini or Chat GPT.
It is by
They
Tesla.
have, it's going to be some.
I hope the grok को हम घूस देना नहीं पड़ेगा मैडम मेरे ख्याल से.
No, it will
So
be
once there is some allegation against you, go to that thing, put your case over there and see what they are saying. And kind of defend
AI will be affecting
every
the most
allegation.
medical profession. Maximum effect will be on the medical profession.
Dr. Srinivasa, you want to say something?
Yeah. Regarding this sensitive testing dose for the local anesthetic, I think only ester-linked local anesthetic are significantly associated with the
We are hardly using it.
sensitivity reaction. And the other thing is regarding the fasting guidelines, I will be sharing all the charts pertaining to the different types of foods and the protocols, our national guidelines in the group. Please, all of you, get the charts prepared and display it in the pre-anesthetic checkup.
It was very nice your comparison of the latest 2023.
Public knows about
Very
it.
nice. Very nice.
Then even our booklet, I mean, so I've tried to circulate the booklet to as many addresses I could. But if someone still requires it and not received it, please send me an email with your email ID, of course, or contact me on my WhatsApp. I will send you a copy. Dr. Rakesh has also made a flip book about it now, so it becomes very
Yeah,
easy
yeah.
to see it on the mobile also. I think we
Yes.
should call it a day, madam. It has
Yes,
been
thank you.
heavy
Thank you
questions
very-
as a session for you, especially. Thank you. I thank all the four.
Thank you very much. Thank you.
Thank you,
I really
sir.
thank all
Thank
the
you
four
for-
speakers for a wonderful discussion, wonderful interaction, and good to have more questions. And definitely, I
Thank
feel in the
you.
next 3-4 months, we'll have one exclusive webinar only on medical legal issues.
Yeah, yeah.
Okay.
Very
Thank you,
good.
thank you, thank you, everyone. Thank you, everyone.
Thank you.
Bye-bye.
Call it a day.
Bye.
Good
Bye.
night,
Good
everyone.
night.
Good night,
Good
everyone.
night. Good night.
Bye.